Heroes, and I'm the Knowledge Mobilization and Community Engagement Specialist at the Edwin S.H. Leong Center for Healthy Children, as well as your moderator for the event. I'm so incredibly excited to introduce our speaker today, Dr. Patricia O'Campo, who's internationally renowned for her scholarship and methods development and one of the first scientists to shine a light on the social determinants of health. She's the executive director of the Li Ka-shing Knowledge Institute, as well as a Tier 1 Canada Research Chair in Population Health Intervention Research. Dr. O'Campo also authored one of the first papers to examine the social and economic factors that affect health, specifically the health impacts of city neighborhoods. Her early research helped shape what is now known as social epidemiology. Today, she continues to push for change, evidence-based health, and social policies and programs to eliminate urban health inequities. She's received Career Excellence Awards from the U.S. Centers for Disease Control, American Academy of Pediatrics, American Public Health Association, and the U.S. Institute of Medicine. Dr. O'Campo is a MAP scientist and the St. Michael's Hospital Chair in Intersectoral Solutions for Urban Health Problems. She's also a professor in the University of Toronto's Dalla School of Public Health and an adjunct professor in the Johns Hopkins Bloomberg School of Hygiene and Public Health's Department of Population, Family, and Reproductive Health. Her presentation today will discuss various strategies for engaging patient partners as well as community members in health research. And I'm so incredibly excited to engage with you all in a much larger conversation at the Q&A portion of this event. I'd like to now hand it over to Dr. O'Campo.
Thank you so much, Priscilla, and really glad to be here and excited that you all have shown up to talk about patient and community engagement on your research teams, in your research. And, you know, we'll talk today about how we began this process. So let me, there we go, deal with technology. Okay, so all right, I'm just going to close this. Okay, so hopefully you can see my slides with the proper view.
Yes.
Thanks. So today we are going to be talking about engaging community members with lived experience or patients on your research teams. And we'll talk about what it actually means to equitably engage those individuals on our research teams, why we should do it, and then how do we start? Because I think that's why we're here. But I think importantly, this session is really about you and for you. And so I want to make sure that, you know, you're ready to think about how you're going to do things differently and be able to ask questions, to be able to get tips and information about pitfalls to avoid. So this is your session. So make sure that you walk away with all of your questions answered. So beginning with what it means to equitably engage patients or community members on research teams. I guess the first thing I want to say, because I do these presentations often, is that when we talk about engaging patients or community members on our research teams, we're really not talking about enrolling them as patients or as participants in our study project. We're really talking about having them participate in the process of research. So I was able to identify a definition from the community, from CIHR, and the definition, which I've slightly adapted, is that patient and/or community engagement in research, or abbreviated as PCER, it's an approach that involves meaningful and active collaboration in a variety of different research activities. Could be governance, it could be priority setting, it could be conducting the research itself, and it could be knowledge translation. And depending on the context, the patients or community members that you involve may also engage people who bring the lived experience for the issue that you're studying, or engaging with affected communities. And so while we're hearing more and more about this work, it isn't anything new, and it didn't begin in the health field, although there are some subfields where this happens all the time and it's fairly routine. An example of that would be HIV research, where we have a lot of community engagement that happens, even community-led research, with community members being PIs on grants sometimes. So it's not new. Some subfields have been doing it for a while, and it actually originated outside the health field. For example, participatory action research has been around for 40 years or so. And the goals of participatory action research were to bring together researchers and community members to identify what the community priorities are that could benefit from research. Also, to enable community members to participate in the research process and to create solutions for the problems that they find important. And some of this was done because there was a desire to make research more relevant, bring it out of the ivory tower. And then also with the ultimate goal being to actually improve the conditions in the community. So participatory action research was some of the early versions of this occurring outside of health, and it migrated to health. So engaging patients or community members in research, it's not one set of activities. In fact, you can have different reasons and different intensities for engaging patients or community members. And I've kind of put this continuum on this slide here. And so examples that fall along the continuum are consultation. So we often hear, let's consult the community, let's consult this group. Consult for a variety of reasons, maybe consult to determine what some priorities are with the population, consult about whether the tools and instruments that we're using are relevant. So there could be consultations, or consult on some findings. So consulting kind of falls along almost in the cooperation area. You might create an advisory group, and that is a form of cooperation where they're going to cooperate with you. The goal of the advisory group probably aligns with the goal of the research study, and they will advise you on various aspects of your research. Going further up the continuum, you might work very closely on many aspects of the study, but perhaps not share power or share budgets or anything like that. And that's more like collaboration. And then finally, if you have full-blown partnerships, and those also take many forms, you might share any one of the following. So share power. So you might allow community members or patients to co-lead studies. You might share budgets. If you're working with an organization, you might share the budget that you get for your research project, share decision-making about many aspects of the study with community or patient partners. So partnership is the most intense way of working with patients and community members. And all of these different ways of engaging patients and community members have implications for power sharing, for resources, how the resources are distributed, for sharing budgets, for the kind of expertise that you hope to have and bring to your research team by engaging patients and engaging community members. And also investment of time on the part of everyone, right? So if you have an advisory group, for example, community members or patient members who agree to that will know how frequently advisory group is going to meet and what their investment of time is. On the other hand, if you have a partnership, and especially if patients or community members are co-leading, then there's much more of an investment in time. So one of the things that has come up more recently is the issue of thinking about equity when we select our partners. And I don't think it's something that we can continue to ignore, because I would say that, especially in health, there have been relatively little attention to equity in the process of engaging partners. So, you know, what we've seen historically is that ignoring inclusion means really relying mainly on individuals who have the ability and ease to participate, to either give time because they're comfortable in terms of income, and they are used to participating in discussions around research or issues. Often they would be individuals who are privileged, who are non-racialized, able-bodied, and higher income individuals. When we see historically who've been, for example, patient partners who come forward and want to be part of research, they tend to be those individuals. And so if we continue on that trend, then we will not include individuals with the lived experience of those conditions that we're interested in, who might be most affected by the issues that we're studying. And so we have to intentionally build in strategies to attend to equity in many aspects of the engagement process, especially recruitment, and then keeping those individuals engaged in the work that we're doing in our research. So, you know, in which of the areas should we consider equity when we're doing this work? Well, there's a long list here, and it's not complete, but and I'm sure you could add to it. So certainly, we want to make sure that we recruit individuals in an equitable way. And that may mean a number of things. It may mean that instead of just, you know, writing up a little description of what you want and posting it somewhere, hoping people will apply, it's thinking about where individuals, if you want individuals with lived experience, you know, where they would most likely see such an opportunity, what they would need to participate. As an example, we have a patient and community engagement and research committee at Unity Health. And when we recruited the patients and those with lived experience to our committee, we did write up what the opportunity was. We posted it different places. We sent it to organizations. We enabled them to get back to us in many different ways. They could call us, they could write to us. When we had a conversation about them, about the opportunity with them, we also gave them many different ways of having that conversation. We could do it in person, we could do it by phone, we could do it by Zoom. We knew that some people didn't have great internet connections. And so we were willing to pay for internet connections if we needed to do that, if somebody joined and they didn't have great internet connection. So we really thought through the various ways in which people might experience barriers to both learning about the opportunity and to finding out more about it, and to participating in interviews, to participate in the selection process, etc. So think about those things when you're thinking about the individuals that you're trying to recruit to your study or your advisory group or whatever you're doing. Certainly in the interviewing, I just mentioned to you some of the things that we did. And on the onboarding, when we onboarded, we thought about they have to learn not just about our institution, but they had to learn, in this case, about a variety of different research topics in which we engage patients and community members. So we really had to think about our orientation. Also the communication strategies, I talked a little bit about that. Payment is a really big issue. So I think that's something that is being discussed even in the literature about what appropriate pay is. And on top of that, for us, it wasn't just a matter of how much we should pay them, it's the way in which we paid them. So we had to be aware of some of the issues that some of our members were bringing forward about how they usually receive payment for these. Is it an honorarium? Is it a salary? So we needed to have those conversations so that we were respecting the needs of those who were coming on board. And then, what are the options for them to participate on research teams? Are you giving them options to do everything? Are you requiring them to do everything as part of your being part of your research teams? Anyway, I'm not going to go through each one of these, but this gives you an idea of the ways in which we need to prepare ourselves, the ways in which we need to prepare our research teams before we even bring somebody on board, the ways in which we need to find out information about our institutions and whether our institutions equitably support bringing these individuals on. There's some work that goes on that's looking at individuals who have a history of incarceration, right? And when we bring on individuals with lived experience, well, we want them to have a history of incarceration, but we have this process which is rather stigmatizing at our organization, where you have to do a criminal background check. So we had to address some of those issues. So how is our institution supporting this process, and what are the processes we have to look at? Anyway, I'm hoping in the discussion that you will also identify some areas, or maybe even in the chat now, other areas in which we should consider equity when we're bringing on patients or community members onto our research teams, and how we should be considering equity. So I wanted to give you a little bit of or share with you some of my own experiences. Actually, that little black strip is blocking the top of my slide, so I don't know which case this is. Let me see if I can get rid of it. Oh, okay, single case experimental design. Yes, okay. So I have this project where I'm trying to refine a particular method. It's called single case experimental design. It's kind of underutilized in the research. And I wanted to use it with some of my work in the area of intimate partner violence. And for a variety of reasons, I'll try not to give you too much background, but the single case experimental design is actually quite powerful. It is an experimental design, and it can give you a lot of information with very small numbers and N of 1. And so we were hoping to test out some interventions using this single case experimental design, or SCED. But we also wanted to make sure that, because some of the data collection can be intense, that we weren't bringing harm or putting any of our participants at risk. And so we ended up creating a advisory committee to co-create kind of safe research protocols. So we wrote up our protocol, our research protocol, and then we shared it with this advisory committee, and the advisory committee was made up of women with lived experience. Some of it was historical, some of it was ongoing, to talk to us about where in our protocol and our research methods, for example, in recruitment or contacting them, or asking them to come in and do things with us, where do we have to build in additional safety measures? So it was an advisory committee. But it really required a trusted survivor to kind of organize and support this advisory committee. There's trust issues involved in women who have relationships that are characterized by partner violence. And it goes beyond just trusting or not trusting the partner. And so we needed to have somebody who was trusted. And so in many ways, it was a survivor-led advisory committee. We relied heavily on the person that we work with on this research study who has lived experience to really help recruit and manage this advisory committee, and really required flexible kind of approaches to even having discussions in the advisory committee, and trauma-informed approaches. So that's just an example of one of the ways in which I have created an advisory committee to inform the work that I'm doing in this revision of this experimental method. So I want to now turn to you and to hear a little bit about from you about what your current level of experience is with patient and community engagement. So we have a Mentimeter or a Zoom survey. I think it's a Zoom survey that I'm going to ask Priscilla to help me with. There we go. So if you can weigh in, there's no wrong answer, right? So I imagine that we have individuals here with a variety of different experiences. So while you're filling this out, I'm gonna have a sip of my water. Oh, somebody isn't seeing the link. Priscilla, are you able to help?
I'll post the question in the chat, and the individual can share their response with me privately, if that's okay.
Thank you. So no rush. We're not going to rush through this session. Okay, I'm thinking that maybe most people are done. Oop, still having some, maybe that was you, Priscilla. Okay, so it looks like many people here have, I'll just go by the most frequent, have a little bit of experience engaging patients or community members. That was something like 59%. Followed by individuals who have a lot of experience. So that's great. We have some people who have some experience and can weigh in on how they have started this process themselves. And then I love it that we have some folks who, this is the first time you're hearing about this topic. So thank you for attending. Thank you for finding out more about the way in which we approach this and what some of the benefits are. And then also knowing something about it, but then wanting to learn more about it. So that's great. We have a variety of experience here. So we actually have, oh, someone else answered, I guess. All right. Oh, are you able to see this? Yeah, right? You all are seeing the results. Perfect. So I think there's one more question. Okay, so the next question then for you is, now that you know a little bit about this, how are you or will you engage patient and community members in your research? So, you know, just give it a little bit of thought and then think about, you know, how you might do it, and think about that continuum. that we talked about. So I need to stop sharing. There we go. So again, take your time, think about it, no wrong answers. Thank you, Priscilla. Okay, looks like, oops, some people are still answering. Don't want to rush you. But a number of people are thinking about actual partnerships or maybe already doing partnerships. So that's great. And then some folks are going to be split between coordinating and then cooperating with patient and community partners. So, and it looks like nobody is not thinking about it, or maybe the people who haven't actually answered yet are still thinking about whether they will or not. So thank you for providing your answers to that question. And thank you, Priscilla, for your help. So let's move on then to more of this presentation. Here we go. So, you know, why should we do it? We haven't actually talked about the benefits yet. So let's talk a little bit about why we should do this. So, you know, one reason to do it is there are increasing calls for engaging patients and community members on research teams. CIHR is giving more opportunities for that to happen. They've changed, you know, some of the CV formats that are allowable now that reflect a increase in the number of community members who are coming on board, for example, or non-researchers really. The SPORE units are supporting this, and researchers themselves are wanting to do more of this because there's this recognition that research is leaving out a key stakeholder from these health studies, right? Patients and affected communities. We need those stakeholders to be at our research tables. And there have been demonstrated benefits. There's been data collected over the years, over the decades, about what some of the benefits are. So, for example, it brings lived experience directly into the consideration or prioritization of our research questions, brings them into thinking about our research processes, and importantly, in the interpretation of findings, also even in the dissemination and uptake of research. So we can really shrink that gap between generating research findings and getting somebody to take them up. When we bring community and patients to the table to be part of our research teams, already we have a stakeholder there who's going to take up some of the findings to act on those findings immediately. It also builds capacity for understanding research among non-researchers or non-research communities. Hopefully, it also would then mean that they would be more willing to participate in research because they understand research better. But it also builds a mutual trust that enhances community engagement with research. When we, especially if we're to use strategies that are focused on equity and inclusion when we bring such members on board. It increases the relevance to the priorities of communities under study of our research. So, our research questions, the context that we bring to consider when we do our research. Our measures are more culturally appropriate. Our interventions are going to be more effective if we co-develop them with affected communities. We don't have to develop the intervention separately and then introduce them to communities, hoping that they'll be acceptable if we co-create. And then power sharing enables greater community self-determination as well. There's some bi-directional learning that happens, and researchers in particular will gain a deeper understanding of the community's unique circumstances. And I already mentioned the issue of faster knowledge translation and uptake. So many benefits. And again, since we have an experienced group here, there may be other benefits that you would add to this list for why we would do this. So wanted to share another case study. And sorry, that black bar is, again, blocking which case study I'm sharing. Okay, now I know which one it is. So this is a case study that I've been involved in for a very long time, 30 years now. And it's a project that began as a national infant mortality reduction project. At the time these monies came out, there was an embarrassing ranking that the US had for infant mortality, and there was a lot of money that was going to reduce infant mortality nationwide. And so it began as a partnership where I, as a very, very early career researcher, it was one of my first projects, was an evaluator for this project. And it was a lot of money coming in. So there was $50 million that came into Baltimore to reduce infant mortality. And they needed an evaluator, and we created a partnership where I was the evaluator. And over the years, we continued to collaborate and still collaborate, actually. And right now, the way in which we collaborate is these initiatives are led by the community to address Black maternal health, and they choose which researchers they want to work with.
Hey, Dr. O'Campo, I'm not sure if you can hear me, but your screen is frozen.
Is in the chat, but don't hit return yet, because after about 3 or 4 minutes or so, I'll tell you when to hit return, and then we'll kind of see a flowing or a waterfall of all your answers together, and then we can review them. So take your time, answer these questions. What are you going to start doing to prepare yourself or your teams or think about equity, et cetera? And then if you're already doing this, what were some of those early steps for you? Okay, I'm going to be quiet and I'm going to let you write down. I'm going to give you about 1 more minute. All right, so I hope that you had some time to think about either what you might do early on or what you did early on. So maybe hope you have your items sort of queued up, and feel free to hit send so we can see what people wrote down into the chat. Amazing, we've got some great answers coming up. So all about building relationships from personal connections and introductions from senior members to other community members, taking the time to go out in person. That is so true. I've seen people say, I'm just going to send them an email and then I'm going to make them call me. So I love that, going out in person. In some ways, we don't think of this initially as a 50-50. We think of it as, on the part of academics, more like 70-30 or 80-20, going out there. Love that. Okay, being clear about with self and partners about the goals and activities of engagement, being transparent with community partners about engagement being a process. Great. I have a lot of experience with participatory and community-based research and learned a lot from equity-seeking community leaders. Great. I'm new to the research institution context and constraints. All right. That's great. Oh, I like that weekly drop-in space dialogue with team colleagues. That's fantastic. First step is to critically reflect upon my own story and social location and biases. That's great. I also ask myself what really drives me to do this work. Yes, I think being transparent about your own goals and what brings you to the table. Fantastic. Academic timelines. Yes, they're always far too short. You know, grants have to be written and submitted within weeks. And if you're lucky, it's months. Or you only have so much time to do the work, or you have to have it all written out about what you're going to do when in fact you're wanting to co-create that with your community. Making connections with organizations that serve the community you plan to engage can help to give background before you actually approach community members, so you're not burdening them. Yes, don't burden them to work to inform you about their needs. That's great. Working very closely with others who have experience working with this particular target group, working with a person who bridges both the lived experience and academic arenas, for sure. It's great if you know both worlds. Identifying, engaging with the trusted advisory leader, building trustful relations with targeted population and organizations serving them, co-work in identifying their priorities and needs, and come together with strategies to collaboratively find, implement, and evaluate solutions. Great. Take the time to build rapport and relationships. So a lot of this is about relationship building. That's really amazing. Absolutely. Asking community members what they need to participate, being transparent about budget constraints or capacity support equitable involvement. Yes. Budgets and being transparent about budgets, I think, is really key. It's part of building trust. Being very transparent about what is and isn't possible to achieve within the study. Yep, more transparency. Cultural competency training, recognizing difference, open to new perspectives, one-on-one engagement, and asking for concerns and suggestions about the project and research methods. So these are all great early steps and first steps. So thank you so much for sharing. Let's see. I think I have a couple more slides left. I'm noticing that it's 11:46. So good that I just have a couple more slides. Just find my. Okay, so start with the PI, where do I begin? Start with the PI prep to take on this approach. We've already heard some great ideas in the chat. Maybe capture the chat, or maybe we can capture the chat so you have learned from people who've done this. And articulate your goals and objective for bringing on patients and communities for that study. Each of your project is going to have a different goal and objective, and ensure you have ample resources. So a couple of people mentioned the budget. Make sure you have ample resources one way or another, and then acquire the skills you need for yourself as a research lead, or if you're part of a team, for your teams, because change always starts with the research team. So we kind of, I wonder if maybe I can skip this case study. If you want to hear about it, let me know in the Q&A, and I'm happy to tell you about this last case study. But what I want to do is clear some of my screen of some of this busyness. There we go. So we developed a little sheet to help you begin this process, since this talk is about where do we begin. Now, I think Priscilla is not on the call, is that right? Because I think she was going to share maybe a link to this, but hopefully every one of you received this. So maybe you're looking at this on your screen. If not, I'm going to share my screen as we walk through this. So, what we need to do is to figure out what is your main goal for engaging patient or community members in a particular research project. And so, there we are. It's in the chat. So if you click on the document in the chat, you're going to bring up a fillable PDF. Thank you. Maybe that's Priscilla. And so, so think about your goals. What are your goals? So that you can start to be clear and transparent. And then also begin to think about, given your goals, what is the right level of engagement that you're planning to use? And again, we used this here, this continuum, and this matrix came from the International Association of Public Participation. And so think about, which is the right level for your goals and objectives for the projects. And of course, it isn't just up to you, but what seems feasible given who you're going to engage. You may want to fully collaborate and get partnerships, but it could be that partners or organizations are too stretched to actually have a formal partnership. I know that we experienced that during COVID. That was my last case study, where we were very engaged with a community. And when COVID hit and partner violence rates tripled everywhere, they were just overwhelmed and in a way had to step back from the partnership. So it isn't just about what you need for your research project, it's also about what is possible. So think about your level of engagement, and then, what are the strategies that you're going to use to ensure that your project is inclusive? So we talked about all the different areas that we have to think about for making sure that we're equitable and inclusive. And so what are some of the strategies you're going to use to make sure some of those activities in research are in fact inclusive and equity focused? Let me just review the last two questions and then open it up for Q&A. So what skill sets do you or your team currently have? What can you build on? What training or preparation does your team need? And then what resources do you need to make this happen, including time? Somebody mentioned timeline and time frame. All of these things take time. And then think about recruitment and then supporting those individuals on your projects. And then how frequently or how will you check in to make sure that your patient or community partners have what they need to participate in a way that's comfortable and that they feel supported? And again, these are just questions that we thought about that would help you early days. I'm sure others can share other questions that they answer before they begin engaging patients or community members. Hopefully you're able to kind of look at that sheet, fill it out, and that it's relevant for you. So I'm going to stop sharing and then open it up for Q&A. So we have about 9-ish minutes to hear from you. Feel free to share. Feel free to ask questions. So great. I've got a question here from Jillian. Can you share more detailed examples of how early research design phase engagement with communities can impact shift? What happens much later during the knowledge mobilization phase? Also, what concrete resource shifts needed to happen for good early engagement? Yeah, so, well, one, so thinking early on in the design phase about your budget and what you need to pay your community members, how much time do you think they are going to need? So in one of my projects, I'm working with a lot of community-based organizations who are serving women who were living with partner violence. And we didn't know if their organizations would support them in participating in research or whether we had to offset their salaries. So that's an early question that came up for us. We put some money in the budget, but we didn't put money for everybody. But if everybody who is sitting on there on the working group and steering committee needed to have their salary offset, it might have been more than what we had budgeted for. And so that could have impacted their ability to participate if in fact that became an issue. So that's one. And certainly if you don't involve members early on and get them to look at some of your research protocols like we did or instruments, it could be that you get to the knowledge translation phase and you realize you forgot something or you didn't use a culturally relevant tool. So hopefully those examples are relevant to your question. Okay, so Maria, hi. How do you deal with possible payment for community participants? Yeah, you know what? That we have had a variety of different experiences with that. We have some community members who just want to be paid. We have some community members who, because they get other, they participate in other programs, they can't have high incomes. So they would rather have these monies that we put aside to pay them for their time to participate labeled as something else. And so I don't have the details in my mind. I'm sorry, I probably should. I don't know if honoraria actually counts as income, or they want it labeled something else. They don't want it to be reported as tax, to CRA as income. And so we have to figure out ways to work with both our community members and then our finance department to get it right. And so we are often pushing back on our finance department to do it in ways that support the needs of each community member that we bring on board. Gift cards. Yes, we use a lot of gift cards in some of our studies. Thank you for that information and sharing that with the community. Maria, that's a great idea. I know that we do give that option, but not everybody wants that option, or they have a need for cash. So then we bump up against what some of the institutional requirements are and pushing back against those. The other thing is our institution takes a very long time to pay. And if you're relying on these funds, they're not big, they're not a lot, but if you're relying on them for your basic needs, we need to pay quicker. So we have tried to set up strategies where we can pay them right away, maybe the same week that they have participated in the meetings. I know that sounds, the same week, it should be right away. And we're working toward that. Okay, so other comments or questions?
Yes, if there are any additional questions, I think we have time for but one more question. Please feel free to raise your hand or type your question in the chat. I really appreciate the level of engagement and conversation with this group. I think those are excellent points. And I really enjoyed the waterfall exercise and reading everyone's experiences in responding to that question. So thank you for your participation in that piece.
Yeah, thank you for the question on trust. I'll just be upfront here that my longer partnerships, we've always run into some kind of a speed bump and had to work through some either miscommunication, misunderstanding, and tension and anger. But when we work through them and we come out the other side, where we've either clarified things or worked through things or come to a new understanding, we have a stronger relationship. But I'm going to tell you, for me, it hasn't been, there's never been one relationship where everything has just been great. I think because what we're doing is we're working on challenges together, and everyone has a different approach to challenges. So don't be afraid of encountering a speed bump and trying to work through it. I think if you do it in a respectful way, that you will come out the other side and have a stronger partnership.
Perfect. I see we have one last question in the chat, Dr. O'Campo, if you're willing to answer it quickly. It's, what sort of challenges have you encountered in your work related to building trust and relationships?
Yeah, I think I just answered that.
Okay, perfect.
Yeah, great. Thanks everyone for your time today.